Good afternoon. Thank you for joining us today. June is Alzheimer's and Brain Awareness Month, and we are excited to provide this special event focused on optimizing brain health as we age, exploring an evidence-based approach with our special guest, Dr. William Mansbach. Dr. Mansbach is the founder and CEO of Mansbach Health Tools, LLC, which supports the BCAT Research Center. And he's the CEO and president of CounterPoint Health Services, a multi-disciplinary behavioral healthcare company specializing in geriatrics and dementia care. And I'm proud to say that Charles E. Smith Life Communities is the BCAT Cognitive Center of Excellence. So you're wondering who I am? My name's Angelique Jackson. I'm the Business Development and Marketing Manager at CESLC. We are a Jewish faith-based nonprofit organization, and we take pride in providing personalized care and experiences tailored to the unique needs of older adults. No matter what stage of life they're in, we offer a variety of services, including independent living at Ring House, affordable independent living at Revit's House, assisted living and memory care at Landau House and Cohen Rosen House, post-acute and long-term care at Hebrew Home of Greater Washington, primary care at Hirsch Health Center, and Elder Safe Center, the first program of its kind in the Washington, D.C. metropolitan area to provide community education, advocacy, and safe temporary shelter to older adults experiencing abuse. So I just want to tell you a few reminders before we begin. We do want to hear from you. We want to take your questions, most likely at the end. So please add them to the chat and make sure you are muted as a courtesy to the other attendees. And also we are recording this presentation. This presentation has been approved for one Category 1 CE credit by the National Association of Social Workers. And if you are interested in a CE or after attending this program, please add your name to the chat. And you will receive an email tomorrow. And then once you receive that email, please fill out the survey and give us about 3 business days to email your certificate. And so without further ado, I will hand it off to you, Dr. Mansbach. Thank you so much for joining us today.
Well, thank you, Angelique, for that nice welcome and introduction. It's good to be with everyone. I'm going to put up a PowerPoint in just a moment. We'll be talking about brain health today, just a couple of housekeeping issues. As Angelique said, let's try to put people on mute, turn down phones. Do think about your questions as we go through. It's a bit easier to answer them toward the end. I'll talk for about 45 minutes. Leave 15 minutes, maybe 10, depending on the content we go through, to answer specific questions. It's difficult for me to monitor the chat room while I'm also presenting the information, so I'll get some additional help in terms of that. And I should say that I'll be talking about brain health specifically in kind of the senior living, long-term care world, but everything I say is applicable to where you see patients and clients in any kind of setting, whether it's at home, home care, or of course, in outpatient settings and long-term care. So with that in mind, if you bear with me for a minute, let me just go ahead and get my PowerPoint. If you cannot hear me or you cannot see what I have, just let me know that and I'll work accordingly. So let me just get this set here and then we'll be ready to get started. All right. Just good. Okay. You should be seeing now my PowerPoint. Let me know if for some reason you cannot see it. So as I said, I'm going to talk about brain health. I'll talk about it in senior living communities, but I want you to be thinking about all the people you work with, or yourself for that matter, and how you can apply what I'm going to be talking about with you today. Some objectives here. you'll hear me say more than once that cognition is a vital sign. I think you would agree with me that just about for anyone who's treating or supporting or caring for an older adult, cognition is just as important for vital living as blood pressure and heart rate and respiration, body temperature and pain, the usual vital signs that we have. So I'll be talking about that. I will highlight how important it is to, whether you use a screening tool or formal cognitive test, it's very important to be able to evaluate where people are cognitively. And that, of course, requires us to understand cognition as non-monolithic, that there are different aspects or different domains in cognition, some more important than others, and I will point them out to you today. Ultimately, understanding the relationship between cognition and function is important. Certainly, people who are struggling with IEDLs are struggling partly because of some sort of cognitive deficit, and we'll talk a bit about that. There are some evidence-based working memory and other cognitive exercises that you can be employing, applying them to your work with older adults. I'm only going to talk about things that have science behind them. I know that there's a myriad of brain training programs that are out there. It's a multi-billion-dollar industry. We're pretty skeptical at a research center, so I'll only talk about that, which we know that there's good science underpinning it. Often people wonder if there's a kind of an organized brain health program that anyone could apply, and there is. And we're going to talk about one that we call the BH7, the Brain Health 7. These are 7 key brain healthy behaviors. I'll go over them in some detail. Time's a little bit limited today, so I'm going to pick and choose what to emphasize. So for example, I'll talk a little bit more about sleep maybe than I am physical exercise. You have access to a lot of information about physical exercise, perhaps less about sleep. So I'm going to pick and choose, as I said. That said, if you have a specific question about something I don't cover, then please put it in the chat and I'll try to address your question in that way. Okay, so cognition as a vital sign. Let me begin with that. This was a surprisingly controversial concept when we first started doing BCAT work in 2006, established the working BCAT Research Center in 2007. Spent a lot of time with primary care. At the time, I was doing a lot of dementia initiatives across the country. But the idea that cognition is a vital sign seems intuitive now, but it definitely wasn't intuitive then. But if you said to a healthcare practitioner, okay, mention a vital sign, and perhaps that practitioner would say blood pressure. If you said, well, is it important to measure blood pressure? I think they would say, well, of course it is. If systolic blood pressure is too high, that could run an increased risk in strokes and MIs and things of that sort. The same with cognition. Equal footing, there is parity there. So it is important that you have the right instruments to measure it. For our purposes today, this is not a webinar on BCAT per se, so any evidence-based assessment that you use that looks at cognition globally or maybe a specific type of certain domain like memory is certainly fine. Just make sure that it has good science behind it. And why is cognition so important? Well, it's at the center of everything we do. It's the great filter. It's the meta activity. It is the thing that allows us to think about and assess other things as we work through our life. And the brain that we have, if you think about it, the majority of the structure of the brain, of the 100 billion neurons that you have in your brain, are focused toward cognitive performance. So that must happen for a particular reason. Finally, I'll just point out that cognition and function are basically two sides of the same coin. Now, cognition can be thought of, I think, on a continuum basis. You can look at different models of cognition that are out there, and there are 7 or 9 different sort of staging levels and so forth. That's too complex and actually not accurate. I think it's better to think about cognition in terms of three buckets of performance, if you will. You can think about it in terms of staging, but that implies, doesn't it, that there's a progression, and there isn't always a progression. It doesn't mean that someone always progresses from normal cognition to mild cognitive impairment and from MCI to dementia and so forth. So we have to be careful about staging, and it might be more accurate to say that there are different cognitive levels. So when we think about normal cognition, that doesn't mean that we make no cognitive errors, right? If we were in a room together and I said, well, you know, how many of you forgot something in the last week? I would think probably everyone would raise their hand. Some people use expressions like senior moments. I'm not sure what that actually means. It sort of sounds like a pejorative, I guess, but I think what people mean is that they made some sort of error. So in normal cognition, we are going to make errors, particularly in attention. We're going to be forgetful, but that doesn't imply that we don't have the ability to make new memories, albeit it might be more challenging to do so. From about age 50 onward, we're going to have those moments where we can't quite think about that river in Asia that we used to know, or somebody's name that we used to know. That in no way indicates dementia. Dementia is about the ability to make new memories, the ability to perform moving forward. So pretty forgiving. In BCAT world, if you think about those of you who use the BCAT, the foundational BCAT test, you would say these are people with scores of 44 to 50 for the most part. And then there's this category that is the slippery slope category, what we refer to as mild cognitive impairment, or MCI. If you're more comfortable with the DSM approach to diagnosis, you might think about this as minor neurocognitive disorder, differentiating from major neurocognitive disorder, which is referred to as dementia. But MCI is sort of the original term. I still like it, although Peterson's initial formulation was not quite right, because it included people with some cognitive issues that had no functional or IADL deficits. We've done a lot of research over the years pointing out that people with MCI actually are pitched on a slippery slope, that in most instances there is at least one IADL problem area. So there are 4 different types of MCI. There's amnestic, where memory is the primary issue. There is executive, where the prefrontal cortex area here, the ability to problem solve and judge, the CEO of the brain, the conductor of the orchestra, all that. That's that executive area. You could have MCI where that's your only problem. You could have multi-domain MCI where you have 2 or more problems. The 2 that are most important for function are what? Memory and executive. And something called undifferentiated MCI, or UMCI. All that really means is a person either has normal cognition and they're struggling. Maybe they're depressed or they're anxious. Maybe they have delirium caused by something else, maybe an infection, maybe the wrong combination of medications, but they don't really have MCI, but they test in that sort of region, beginning region, so they still have pretty high scores. Or it could just be that these are people who are just entering that stage of MCI. In terms of the BCAT, these would be people across the board, 34 to 43. So people in the 42 to 43 range are probably people with undifferentiated MCI. Now, why are these subtypes important? Well, they're important in part because they identify the specific cognitive domain that's a problem. So if you have a patient who has amnestic MCI, it's important to know that, because memory is going to be their problem. If you are treating them in their home and they're managing their own medications and they seem to understand their medications, but they could make errors in remembering to take their medication, that would be an amnestic problem. But not only do they tell you what cognitive domain is most at risk, They also give you an idea of progression to dementia. So basically, those who have MCI, 10% of them are going to progress every year to dementia, pretty high number. There were some studies that said that the number of MCI progressions is relatively low, and lower than what we reported in the literature, a few years ago. But actually, if you use a cognitive test like BCAT and not a screening tool like MoCA or SLUMS or MMSE, something that's a little bit more robust, you actually see conversion taking place. We think that anywhere from 30 to 70% of people with MCI will convert to mild stage dementia within 3 to 5 years. So conversion is an important thing for us to really think about. How prevalent is cognitive impairment? Well, it's pretty prevalent, 25 to 30% of those who live in residential settings. Many of you work in them. Let's say people age 65 and greater, although really you can move the clock back to probably 50 or 55. About a third, anywhere from a quarter to a third, are going to have MCI, and 50 to 60% are going to have dementia. Of course, if you're in memory care, probably 100% are going to have dementia in that particular kind of program. What about home-based settings? In the community, about 15 to 20% of all older adults in the US have MCI, if you are going to actually assess them. So how many have dementia? Sometimes you think, my goodness, everyone has dementia. Seems that way when that's your work, your life's work, but actually it's more like 11% from age 65 to 100. However, risk goes up with age until it doesn't. And so that's sort of a strange way of describing it, but if you really look at the literature, you notice that people who do not have dementia at 85 probably aren't going to develop classic dementia, even if they live for another 15 years. So I actually think that it's a little misleading to say that with every 5-year increment, you're going to move the needle toward dementia. It doesn't always work in that way. Okay, so I'm going to talk a little bit about evidence-based tools and why they're really important. So the first thing to think about here is that I want you to think, okay, how do you approach an older adult who you may be working with if you think about cognition as a vital sign? I mean, how do you assess where they really are? And how many people use evidence-based screening tools? Well, you may be interested to know that in 2015, 2016, I'm trying to remember when it was, at our research center, we had a CMS grant, Medicare grant, and one of the questions was, how good are healthcare providers at identifying people with dementia and differentiating dementia, particularly mild stage or mild level dementia with MCI? And what we reported is that not actually very good, that only one healthcare discipline or category was able to, at the 50% level, differentiate between MCI and mild stage dementia. So what it said to us and what we reported to them was that you really need to have some sort of standardized test, or at least a screening tool in your toolkit to be able to do this. You really need to know who has dementia and who doesn't, and who's really at risk. I also would say that there's a direct relationship between advancing or increasing deficits in cognition and increasing deficits in activities of daily living, particularly the more complex or instrumental ones. You see this, right, with people who are managing their medications. Maybe it's community mobility, maybe it's financial reasoning, that sort of thing. So if you're in a center, let's say you're in a nursing home and you're discharging people, you really do need to know where they are cognitively, because that's going to help predict what's going to happen in terms of your the risk profile, the adverse events that could happen to another person. I also think that if you want to create an appropriate discharge or a care plan, you have to know if this is going to involve other people. And of course it is if a person has moderate or severe stage dementia. Just a quick word about BCAT. Angelique had mentioned that Charles E. Smith is a cognitive center of excellence, so they integrate a lot of BCAT tools, so they have very good science there and very good outcomes. So if you don't know about the system, BCAT's an ecosystem. So it has 6 primary tests, a number of secondary ones if people want to do them. Those tests point you to specific interventions. Again, they have to be evidence-based. In other words, they have to work. A lot of the interventions are focused on working memory. I'll try to talk about that in just a little bit. And brain health is a very important part of this. And I think that you would say, if you're working with someone with normal cognition and they're older, they probably want to hold on to it. So brain health is about then maintaining, at least maintaining cognitive skill. If you're beginning to have some issues, then probably you're looking at people who want to improve, but also slow down decline. And if you're working with people who have dementia, I think you're really trying to improve meaningful engagement, which tends to lower agitation, tends to reduce the necessity for us to be able to, prescribe psychotropic and other kinds of medication. You do want to reduce cognitive decline, slow it down to the extent that that is possible. But I think you're really trying to create opportunities to not have those agitated behaviors, what we call the BPSDs, or the behavioral and psychological symptoms of dementia. BCAT has 6 tests in the test system, as most of you know. The foundational BCAT, which has factor scores for memory, for executive skill, for attention, and something called the CTM, the Cognitive Task Manager, which can predict a lot of things like falls and rehospitalizations and so forth. The BAS, the Brief Anxiety and Depression Scale, is often used to assess risk for generalized anxiety disorder and depression. They're tests of judgment, a number of things. I'm not going to go into great detail. If we think about senior living communities, the sort of array of them, from life plan communities to standalone memory care communities to other integrated communities with, let's say, AL and IL, or maybe AL and MC, or AL, IL, MC. If you're looking for certain outcomes, what we're concerned about at BCAT is, how do you leverage the best tools with the best science to produce the best outcomes? So the 2 ways of doing that: you can be a certified community if you choose, or you can be a cognitive center of excellence like Charles E. Smith. The latter is much harder to do. It's a higher lift, heavier lift, I should say, but very good outcomes. And it's a 360 model, so that there are programs for residents, for their families, and for the staff. Okay, so that said, sort of by way of introduction, I'd like to talk about brain health specifically. And I'd like to begin by saying, I think you could get 10 people in a room who don't know one another, who don't work with one another, and for whom you could pose the question, tell me in your own words, what is brain health? And I think you're going to get maybe not 10 completely different explanations, but some rather differing views. So the World Health Organization, recognizing that brain health is confusing, came up with a definition which is also a little confusing. Brain health is an emerging, I get that part, growing concept that encompasses neurodevelopment. Okay, plasticity, I think means change, functioning, and recovery. That recovery thing, I think we did the italics for that, across the life course. So what's that supposed to mean is that it's an emerging science that's very applied. It somehow involves the neurons and how the neurons communicate with one another. that it changes over time, that to be brain healthy, we have to accommodate, make changes, that's plasticity, that it impacts on our functioning on a daily basis, and that somehow brain health must not just be about learning how to connect dots on a screen for a game, but it should help us recover when we have neuronal loss, some sort of problem. At our place, we think about brain health a little differently. And so we think about it in terms of positive brain health and maybe less positive brain health. So positive brain health implies optimal structural integrity. That means that the parts of the brain are working well. So that's important. That there's a preservation of strong cognitive and psychological skills that really impact daily functioning. So if you think about it in that way, it's dynamic, which means it's changeable. You can make it better and it can get worse because things can happen to you. And it's determined by a combination of heredity, which you're born with, and your experience, what you do with it. So it has very meaningful application. I don't care if you're talking about someone with normal cognition or someone with dementia. You can practice brain health with people with dementia. It's just that the goals, the strategies, and the tactics must differ. Not only that, within the continuum of dementia, mild, moderate, severe, you can practice brain health all the way through. But again, how you do it must change, and that comes back to those cognitive evaluations so you know where somebody actually is. What do we say? We say, what I am born with, what I do with it. One has agency. So there are things that you can do about it, I guess, is really what we're trying to say. Not going to spend a lot of time on this, but if you're interested later in thinking about cognitive levels and community goals for brain health, we have a lot of information about this because we've done a lot of research in this area where we look at people with normal cognition, MCI, mild dementia, moderate to severe, where there are different goals. So if you are in a senior living community and you're thinking about people with normal cognition, it might be 5 to 10% of your population there. Maintaining and building what we're going to describe as cognitive reserve becomes a priority. If you're working with people with MCI, improvement in working memory becomes really critical, right, for you. And function, that is, can you get to the dining room okay? Can you participate in activities? Can you maintain as much independence as possible with the 10 to 13 key IADL areas? In mild dementia, you still can improve working memory abilities. So this is important. Just because you have mild stage dementia does not mean that you can't get better. And you're working against time, swimming upstream, so efficiency is important. And of course, independence is important. And then this last category, moderate to severe dementia, the emphasis is not so much on working memory, it's more on meaningful engagement. So if you're thinking about it from the paradigm of senior living community, there is nothing more important than life enrichment. So I'm going to say that again, not to irritate nursing, docs, other people, but life enrichment is really where you need to invest. It doesn't mean that the other areas are not important. Of course they are, but how we spend our time is really at a premium here. Okay, so let me go back to the concept of working memory. It's important, so I want to spend a little bit of time talking about it. So we make memories starting with working memory. So I'll show you a sort of a picture of a brain and kind of talk about it just a little bit. But from a conceptual standpoint, it's really that limited initial storage that we take on new material. It's basically initially coded in the prefrontal cortex here above my forehead where I'm pointing. That information has to be coded. It has to be sent down to the limbic system in the hippocampus where it has to be indexed and stored somewhere. Working memory only lasts 0 to 30 seconds. That would mean that to learn something new, you have to begin a cognitive process of memory within 30 seconds. or you won't be able to do it. The material is already gone. If you have MCI, it's 10 to 15 seconds. If you have moderate stage dementia, it's about 5 seconds. So if you're working with someone with moderate stage dementia, maybe they have a BCAT score of 20, and you're trying to work with them, let's say on morning care, you would not want to use instructions, sentences that have more than 5 words, because you're going to go beyond the 5 seconds. Your resident or your patient won't remember what it is that you were telling them, and then they're going to get agitated. So these things are really important. So working memory involves the ability to attend and focus long enough to bring some executive strategy in place so you can do something with it. When you measure working memory, like through BCAT, the question really is, can she hold on to information long enough to use it? I think that's kind of a practical way of thinking about it. Working memory gets worse as progression of dementia or cognitive decline. It involves a lot of parts of the memory, the brain, but particularly the prefrontal cortex. Okay, so this is kind of what it looks like. So here's our brain here. That prefrontal cortex is in green. It captures the information. It sends it down to the limbic system where the hippocampus is, that blue thing. It indexes there, and then the hippocampus sends it out. Memory is stored throughout the brain, but personal memories, what we call autobiographical memories, are actually stored pretty close to where the hippocampus is because it's easier to catch them. Now, we will be presenting, I think in the late summer or early fall, a webinar. It's probably a 2-hour webinar just on memory. How do we make memory? We'll get announcements there. If you're not a member of BCAT, it's a free service. Your information isn't sent anywhere. It's just a way of getting information about new things that are going on in the research center and new things about memory and function. You can just go to the BCAT website and you can register, and you'll find out about this memory webinar. So working memory has different time windows. As I said, normal cognition up to 30 seconds. People with memory MCI or amnestic MCI, it's more like 10 to 20 seconds. Mild to moderate, 5 seconds. So that's sort of MCI to dementia, mild dementia, maybe 8 to 10 seconds. It depends on each person. These are just averages. So I'm asked this question all the time. Can you really increase working memory? If the answer is, can you grow neurons to improve working memory? The answer is no. We don't know how to grow more neurons, even though there are people who say that we do. I see zero evidence that we do. So it's difficult to improve capacity, but it's not difficult to improve efficiency. So if you, in real life, moving someone from 15 seconds to 20 or 25 seconds is certainly doable and enormously impactful in everyday living. Okay, so how do you do it? Well, you do evidence-based working memory exercises, and there are prescribed ones. If you want more information about that, we can certainly let us know, and we will make specific recommendations. Assess for depression, because depression, anxiety, and poor sleep are subtractive of working memory. There are other comorbid conditions, other healthcare conditions that can subtract from working memory. There are medications that negatively impact it, particularly those that are sedating. And we always say, look, if all else fails, move your body, move your mind, move toward others or move with others. Improves working memory. Okay, a little thing about cognitive reserve. You know, in the 1980s, there were a couple of studies that came out, and they were looking at imaging. This is the first time we were really looking at functional MRIs and things of that sort. And that's when we began to notice that the plaques and tangles that are characteristic of Alzheimer's disease, that there were a group of people that didn't have them. And not only that, there were another group of people that did have them, but they didn't have any symptoms. So why was that? So the whole concept of cognitive reserve evolved to try to explain, are the things that you can do to kind of, it's like storing acorns, right? You know, for the winter. And apparently you can. And so cognitive reserve is informed by and improved by cognitive exercises and a brain healthy lifestyle. I think what you would say about people who have high cognitive reserve, they have no more neurons than anyone else does. But the connection among neurons is much, much greater. And in recent years, there's a hypothesis that says that people with high cognitive reserve naturally, biochemically, are able to break down the stress inflammation cycle, which may explain why we have cognitive decline, and is one explanation for how Alzheimer's disease develops. Neuroplasticity, I'm just going to drop this in here, not spend a lot of time talking about it, but neuroplasticity is a natural thing. It's not hocus pocus. It's not magical. It's just the brain's natural ability to rewire itself, and it does it all the time. All the time. I had this conversation, was working with a neurosurgeon in Philadelphia on this idea of neuroplasticity in patients who have neurosurgery. And he had observed that neuroplasticity was occurring in patients post-surgery. They were taking on improved function. And if you looked at functional MRIs, you could see where this was taking place. So neuroplasticity is a real thing. What you have to be careful about is claims that these programs that are out there actually produce it. They don't always. There are two types of neuroplasticity, functional and structural. In the interest of time, I won't spend a whole lot of time actually talking about them. But the important thing is that neuroplasticity is natural, and you can promote it. You can in some ways advance it by brain healthy behavior. This is a neuron, and the only reason why I'm going to share this with you is that in neuroplasticity, the connection among neurons grows. So rather than having 500,000 neurons communicating on a certain task, in neuroplasticity, you're recruiting other neurons. So there's a relationship between neuroplasticity and cognitive reserve, and it works kind of like that. So I mentioned this before, sort of a kind of a sticker shock idea that most people have between 80 and 100 billion neurons. They're connected through these synapses. There are probably 1,000 trillion of them, 125 trillion just in the neocortex here. That's a lot, isn't it? I mean, who can count that? So these are kind of interesting estimates. But how the synapses connect with one another and disconnect with one another is a dynamic process that happens across the lifespan. I will tell you that as you sit here and you listen to me talk about this, the natural part of aging means that we have degraded connections across synapses, synaptic connection, just as a function of aging. So it's very important that we're proactive in our brain health to make new connections. So, and you do that through the Brain Health 7 that I'm going to talk about in just a moment. Now, sometimes we do this as a sort of as a poll question, but it's a short webinar, so we're not doing it today. It turns out that the number of synapses per neuron or connections per neuron is greatest not at age 30, not at birth, but at age 3. Kind of goes downhill from there. So as you look at this, this is because the rate of brain development, not just in terms of tissue, but in synapse connection, really accelerates. It also explains why children, very young children, under 3 and certainly under 4, are only capable of certain, let's say, executive things because there are just not enough synaptic connections among these neurons. Sort of interesting. Okay, so let's talk a little bit about brain health programming, different options that you have depending on where you are. So I think it's fair to say that for people who have normal cognition, MCI, mild stage dementia, and some with moderate stage dementia, the goals are going to involve trying to improve cognition and function. Certainly try not to lose any more cognitive ability and its related functional ability. To do that, one has to, from a life enrichment standpoint, add certain stimulating kinds of exercises. That should be integrated from an evidence-based standpoint into everyday programming. In independent living, you want to build cognitive reserve as much as possible, because as you age, your brain is under assault for a number of reasons. You want to be able to rely on that reserve. That means that working memory exercises, which is only one of the 7 brain health things that I'm going to talk about, they need to be challenging. So we say frustration -1. You go to a level that's really hard, person's ready to give up, then back down to 1. It's one way of doing it. So practicing brain health on a daily basis is important. In assisted living, cognitive health and wellness remains a priority, of course. Working memory exercises are still really important. Cognitive stimulation, important. Brain health, important. In memory care communities, there's more of a focus toward programs like MEMPICS, meaningful engagement, creating opportunities for people to stay connected in some ways. Activate old memories rather than pushing the development of new memories. And actually mitigating the BPSDs as much as possible without always using medications. That's important. For exercises to actually count, they should be progressively challenging. They should be frequent. We say 5 times a week. 3 is good, but 5's better. Use exercises that have some science to them. So there's nothing wrong with crossword puzzles and a lot of the games. They're fun. I wouldn't discourage you from using them, but I wouldn't say that they're your cognitive exercises. So science actually matters here. But cognitive exercise alone won't get it done. Now, in everyday life, we have certain subtractions to brain health that we need to manage. Just normal aging, our neurons start getting smaller, connections are less efficient, we begin to lose some, sometimes in great number. Poor lifestyle habits, poor sleep, not moving your body enough, alcohol and substance abuse, untreated depression, persistent anxiety, and of course, underlying conditions like cardiovascular disease, tumors, and chronic inflammation, one of the really big ones these days. So I'd like you to think about brain health programming. Again, whether you work in a older adult community, or you're just working with older adults, or you're just someone who wants to improve their own brain health, working your brain is one thing that's really important. But there are other things that are really critical to be thinking about. So I'm going to talk about the BH7 right now. These are the 7 kind of brain healthy behaviors. There are more, of course, but these are the 7 that demonstrate the best science. And I think that there's something that almost anybody can do. So you will see them. Physical exercise, a minimum of 10 minutes a day. That's not very much. Cognitive exercises, but a specific type. Working memory exercises with good science. Centered breathing or meditation. Diet. Social engagement. Mood functioning. That's basically treating depression and anxiety. It doesn't mean that being depressed or being anxious means that you can't have good brain health. It means that they represent risks for you. So untreated major depression and untreated generalized anxiety disorder, that you don't want that. Treated is fine. And the importance of sleep. So this would be a program. I'm going to skip this for right now. I'm going to talk about subtractions to brain health, and then I'm going to dive in just a little bit more detail on the specific behaviors, these 7 brain healthy behaviors, and then we can take questions and answers. Normal aging involves entropy. Entropy is a second law of thermodynamics. Sounds really complicated, doesn't it? But it isn't. It just means that over time things decline. And everything does, our heart, our lungs, so too does our brain. It's just a reality. So we have to work hard to reverse entropy. As I said, poor lifestyle behavior. chronic poor sleep is a real subtractive issue, as is accumulated stress. So I'm going to jump down to these behaviors and talk about when it's positive and when it can be subtractive. Physical exercise, you know, you don't have to work out for an hour every day. Sure, that can be good, and I'm not saying that you shouldn't, but 10 to 15 minutes or short bursts of moderately intense exercise in a way and in a fashion that you find useful and effective and doable, sustainable for you is fine. That could be going up and down steps. It could be power walking. It could be, if you use the 15 for Me app, you could be using any of the different modules that are on there. You want to get your body moving because that improves cardiovascular blood flow, and blood flow is critical to neuronal health. Pretty simple. Cognitive exercises, what I would say about them is they're not all created equal. Certainly, we advocate for BCAT working memory exercise books because we know that the science is good, but you don't have to use those. Use anything that has good science, anything that there are studies in the professional literature that demonstrate that people get better in terms of their brain health. Centered breathing, you know, it's easy to think about how breathing that is parasympathetic, it is calming, it slows down your central nervous system. It suppresses the release of stress hormones like cortisol, which is really good. It promotes the growth of maybe the best happy neurotransmitter, serotonin, which is actually manufactured in your gut, not in your brain. It's really good in that way. And we were doing a fair amount of research on specific working centered breathing videos for people with dementia. It's called Engage Your Senses. If we have time, we'll talk a little bit more about that. And what we've been able to demonstrate is that agitation goes down when you do these kinds of breathing. Diet's really important. It's never too late. We use the MIND diet quite a bit. I think that that's really a diet, particularly with its emphasis on the right oils, the leafy vegetables, and the subtraction of things that aren't very healthy, high fat, high saturated fats. Pretty simple. There's a resource for that in the book, Brain Health as You Age. There's a whole section on sort of the do's and don'ts of diet and brain health. You know, social isolation kills. It's really dramatic to say that, isn't it? But we learned this with COVID. More people died from social isolation than they did from the actual virus and related medical problems. So everyone has a different set point for that. Some people really like to be with a lot of people. Sometimes it's just one person, but it's important to find that baseline for the older adult and make sure that there is a social engagement. I talked about mood functioning already. It's not being depressed and being anxious per se, but not managing or trying to reduce those symptoms that are really important. And sleep. So sleep is so much about circadian rhythms and the management. The circadian rhythms do so much, like regulate our mood, have an impact on cognition. So we really do need 8 hours of sleep. We do entire hour-and-a-half webinars just on sleep. It's that important. We think it's probably just as important as a life activity as diet is and hydration. It's gotten short shrift, I think, over the years, but it's really important. And in terms of managing BPSDs, it's critical in that regard. Okay, so we have a number of resources that you can check out. enrichvisits.com. This is a free resource. You can do the Enrich Calculator, which gives you an idea of brain health and kind of how sort of good a person's doing right now in terms of that. There are a number of different programs. 15 for Me is something that you can find out about. And now, as promised, I want to make sure that we have time for specific questions. And maybe either Angelique or Abby Williams can help through the chat room. See if I can answer any questions people might have.
I do have one question here. Let me see here. If you nap for an hour during the day, is that helpful to add into your 5 to 6 hours of sleep that you regularly get? That's a great question. I feel.
Sure. So most of the research is on volume sleep in a 24-hour cycle. So as long as sleeping or napping doesn't interfere with your sleep capacity at night, it's a perfectly good thing to do. And just to expand on that a bit, if you think about sleep in terms of stages, I mean, everybody knows that, you have REM, right? Rapid eye movement as a stage, and that's fine. And there's certain things that happen there that are really important. But you have three other stages that are important. You have, sort of light, moderate, and more heavy stage, which is slow wave sleep. But slow wave sleep is so critical because that's where you clear things like beta amyloid and other toxins. So if you don't get enough of that, doesn't mean that you're going to develop Alzheimer's disease, but it does mean that you're less efficient in clearing true toxins in your brain. So it is important that take place. We also know that if you're working with people who have dementia, that you get that diurnal shift, right? Where people are up at night and they're sleeping during the day. That's a problem. It really is a problem. Even though there are programs that say, residents live here, they can sleep and get up whatever they want, it's actually a bad idea because those circadian rhythms require, for proper maintenance, people to be up during the day and sleep at night. So it's pretty critical in that way. Take your nap. I think it's always good.
Thank you. Well, she's asking a follow-up question. She's just asking, what's the second sleep after REM? She couldn't hear you very well. Wasn't clear. The second stage.
So you have these beta, theta. One way to think about it is you have light sleep, twilight sleep, light sleep. And that's the kind of sleep where you're not really sure that you're asleep or not. You can be easily startled. Progresses, and think about it in terms of the waves, the electric waves that you have, activity, brainwave activity, into an intermediate stage. It is the bridge to slow wave sleep. So it's 1, 2, 3. 3 is really restorative. I mean, REM sleep is very restorative too. It does different things too that are really critical. So 1, 2, 3 REM, 1, 2, 3 REM. You usually go in that cycle. However, if you're someone who's been sleep deprived for a long time, you don't stay in that cycle for the same duration. You might get to deep sleep really quickly. Your brain's really good at knowing what it needs. The other thing, it's not a follow-up question, but I'll just add it. People are notoriously bad in reporting how much sleep they get. So we aim for 8 hours, and somebody might say, well, I consistently get 6 hours. The problem is that when we're asleep, like in stage 1 sleep, we're not really aware if we're asleep or not. So it's a hard thing to really assess. And when you look at sleep studies, they consistently report that people sleep actually more often than what they report when they're actually at home. So it's just kind of a thing.
That's interesting. So our next question, and thank you for that question. What are some functional activities or tasks that could be helpful to use during therapy to facilitate working memory in addition to the workbook you mentioned?
So, dual tasking can be really good in that you're trying to get people to, anything that's going to expand attention and at the same time get them to learn a new strategy is really good. But if I can just share a caveat about any kind of dual processing. If I said to you, do you think, which is different than multitasking, but it's relevant in this way. If I said to you guys, okay, do you take pride in your ability to multitask? Would you say yes? Would most people say that that's like a virtue?
I know I would.
You're looking at me like it's a trick question. I know you are, but it is. So the problem with multitasking is that it's the enemy of making new memories. That actually we can't multitask. We can only switch from one thing to the other and back again. So if you want to learn something new, whether you're in rehab or not, don't multitask. If a person's already learned it, or they're pretty far away, pretty far down the road and using it, then you can add some other things, and that could be really, enhancing in that way.
Thank you. So the next question is learning a new task more beneficial than increasing your learning on an existing task? For example, learning a new language versus continuing to focus on one you already have been learning, or learning a new instrument versus continuing to learn an existing one.
That is such an A+ question, and it's a very complicated one because they're both really important, but they do different things. So from the standpoint of neuroplasticity, learning brand new tasks is really important. And so I would suggest that you do that. On the other hand, schematic learning theory means that we're actually better at learning things that are related to what we already know. If I'm working with someone, if I'm dealing with myself, I think it's a combination of both. What do I already do that I like, that I can get better at? And what can I do that I haven't done before that might make my brain better for building cognitive reserve? If I'm working with someone with mild stage dementia or MCI, though, I'm probably not going to introduce at first a brand new task. I'm going to build on the schema that's already there in some ways and try to integrate that as much as possible. So it's sort of like tonight, if you have to move furniture from one room to another, and you have a choice between picking up the sofa yourself or getting somebody to help you do it, you probably want someone to help you do it. Well, that's sort of an analogy for if you already know how to do something, but you need some help. That's like, okay, I know this language, but I want to learn a little bit more about the culture of the language. So it's related. It's not a brand new task in some way. So with more impairment, stay with what you already know, just build on it. With less impairment and you just want to try something new, great for your brain for building cognitive reserve.
Thank you. What a great question. Our next question is, do deep breathing techniques, as you know, for instance, ones that are practiced with yoga, do they help in brain health in any way?
Yeah, maximally. So I think that the evidence is really clear. Any kind of breathing, deep breathing, is good for the brain. And I can explain the neurophysiology, although probably not in 3 minutes, but in a very simplistic sort of way, when you do deep breathing and you engage the parasympathetic nervous system, you say no to the sympathetic nervous system, which is your fight, flight, freeze, one of those 3 things. Those stress hormones like cortisol, when we're stressed all the time, they degrade the hippocampus eventually, and that's the seat of memory. So any kind of breathing is important. I mentioned this 15 for Me app, which has some really good evidence behind it. Focuses on 3 C's of stress reduction, but they're also, you can think about it as a sort of a brain health app. So there's cardio, there's cognitive, but there's centered breathing. And the whole idea is to, how do you maximize that? There's tons of apps that are out there. You can use any of them. Go ahead. I mean, they're all helpful to some degree. I will say if you're working with people who have some cognitive issues, you need to use an app where the center breathing combines the right kind of script voiceover that takes working memory in mind, but that also has a visual component, because it's the visual component that is the tether, and the real relaxation part is the auditory part. So you have to work hard to find those that have some science behind them, but they're really good. So that was a really long-winded answer, wasn't it, to a very good question.
Well, I think that's all the time that we really have for questions, as I do want to be mindful of Dr. Mansbach's time as well as everyone else here on the webinar. And I just want to give a great big thank you to you, Dr. Mansbach, for
Sure,
your
happy to do
time and presenting over this very difficult topic, but one that's very interesting. I also want to just remind everybody, if you are looking for your CE, please, once you receive the email tomorrow, fill out the survey and give us 3 business days to get your certificate back to you. And then also I put a link in the chat to show all of our upcoming events. Our next event we do have is July the 10th. It is virtual as well, at 10 a.m. where we will discuss all things long-term care insurance. So please join us for that as well. And again, thank you to everyone who attended and have a wonderful afternoon.
Thank you.